Okay. Reproductive rights are a very complicated issue in this population. Do you think you could comment on that, please?
Sure, absolutely. So, when we first started in this space, we were seeing patients who were where reproductive rights became a method of coercion. So, for example, forcing somebody to engage in forced sex work or using sexual violence to coerce somebody into labor work without the right of reproductive choice by the victim of labor or sex trafficking. Um, Meaning they didn't have a choice to engage with say in forced sex or sexual violence in a safe way and would sometimes become pregnant. And then the pregnancy state puts somebody in a vulnerable position, meaning now you're not working to make choices to protect yourself. You're also making choices to protect an unborn fetus. And so if a child is born into trafficking, you now have to make decisions that protect you as well as a new child. That may be a barrier to the disclosure, for example, for fear that if they seek services from a healthcare provider um, or the police, that for some reason they may not have access to their child if that child was put in harm's way during the time they were being trafficked. Um, it also becomes a way of controlling people's behavior. So the fear of physical violence toward an individual changes when they could lose a pregnancy. And so we've seen patients whose physical violence is so extreme that they lose the pregnancy because of the harm that's incurred during both labor and sex trafficking. And then we see the loss of reproductive autonomy as a form of control. So forced impregnation, as well as forced termination. So in states where access to abortion is limited, we do worry about the loss of reproductive autonomy when patients are victims of labor and sex trafficking who are forced into pregnancy and then don't have an option to access care unless they leave a state. And so the pregnant female patient becomes very vulnerable, we know, to domestic violence and other forms of violence. And so that's even heightened in times of trafficking. We also want to think about, when we think about sexual violence, we automatically think that women are the victims. And we want to keep in mind that men can also be victims of sexual violence, whether they're trafficked for sex or whether they're trafficked for labor. That sexual violence towards men can also be used as a form of force. And we talk about that means of force, fraud, and coercion.
And this is painting a very sad picture of the lives that an individual who's trafficked might experience. So I'm pretty sure there's a lot of injuries in that setting. Um, are there any common ones? Are there any patterns in that trend?
Yeah, that's also a great question. When we tell people we work in the anti-trafficking space, they think, well, you're a psychiatrist, and that's probably a distressing thing for somebody um, to experience. And so, of course, they're seeking mental health care. But actually, it's the emergency medicine doctors that really started the public health wave of human trafficking. They were seeing patients coming into urgent cares and emergency rooms for all sorts of injuries. I always think about it like it's hard to sell someone who's injured or unable to work. So if we think about labor trafficking, we want to think about repetitive stress injuries or exposure to, if they're working in agriculture by force, exposure to pesticides, or injuries that are not, where they're not given an opportunity to use appropriate protective equipment. And so they may get chemical burns, or they may get injuries to the torso when they don't have access to protective equipment because they're not abiding by OSHA guidelines because they're too busy being trafficked. So why is somebody who's working in a factory or on a farm getting this injury in the first place? Should be something a clinician thinks about. When it comes to sex trafficking, often it is injuries related, as you would imagine, to sexual violence. So infectious injuries or or bleeding or tears that require medical interventions, or some sort of injury related to the head and neck. We've written a paper just recently about strangulation related injuries, injuries to the head and neck and eye related to violence perpetrated by either a trafficker or a buyer. But if you name it, we've seen it. So we have written papers in the PM&R and rehab space related to traumatic brain injuries from labor and sex trafficking, in the obstetric space, in the pediatric space, in the plastic surgery space. We have patients who are forced to have illicit plastic surgery to make them more attractive, and then they have complications from that, severe complications from that. So
I think it's worth bringing up, though, to the audience that people who traffic for a living, people who are running these individuals, have a lot of means of medical treatment. So for somebody to come to us, they would have to be either very injured or in some other way incapable of being taken care of by their trafficking or their trafficking
sure.
team.
That's an excellent point. They either can't be sold, they can't work, or they become a liability, where they either are an infectious liability or somebody's going to take notice if somebody's too injured, and they could be identified in the community. So usually when they do come as well, they're, because of that concern for identification, they come in late stages of injury. So, for example, if somebody gets struck in the face and they have a tooth fracture, and instead of seeing a dentist early on, it's not until there's a large abscess and osteomyelitis when they present. So it's really late stage of very common injuries and findings that should make you wonder why somebody didn't access healthcare sooner.
I've always heard that pimps have a lot of medications to offer before they take somebody to the ER.
Yeah. So, I think nobody wants to bring their victim to the ER. I think especially now, because there are laws that require healthcare workers to get training in human trafficking. And so the more astute we are as clinicians and public health responders, we don't want to spook people from coming to emergency rooms to get care or to be brought in for care.
And I think one of my favorite papers of yours is the one about branding, tattoos and branding. Do you think you can comment on this?
Sure. So that paper came from a patient that we had identified whose name of her trafficker was branded across her neck, like a collar. And I thought to myself, she must really like somebody to commit to branding someone else's name across their neck. And so she had been trafficked. She'd been a victim of commercial sexual exploitation since she was a minor, and had been trafficked as an adult. And not uncommonly, the branding is a way for trafficking rings to identify their victims. So there's some element of social value to it, I guess, if you are a trafficker, to brand somebody like they would in a labor camp, the same way they would as somebody who works for a certain group. It's a great way for clinicians to identify affiliations, whether they're forced into labor or forced into sex, especially if a patient doesn't realize that's what's happening. So if you're talking about a 15 or 16-year-old boy or girl who may not realize that they're being exploited and think that this is the norm because it's what their peers are doing or what others in their community are vulnerable to, it may be a way of identifying victims in a clinical setting. It is used, actually, interestingly, in identifying victims in the forensic setting. So So criminologists, detectives, police, they actually use tattoos in other ways. We don't think about that as a clinician. So it's from our patients that we've learned about these tattoos. It's been reported in the OB-GYN literature and the anesthesia literature that clinicians have been able to identify victims just based on these tattoos alone. It also opens up a way a conversation about why they have this person on their body, and was that by choice or by force.
Yeah. Right. It's a lot like slavery. It makes human trafficking very reminiscent to slavery.
Very much so. Well, they call it modern day slavery. So it does have that name. But I think that it's I would say it's different, because when we think about slavery as being often forced labor. And this is forced, all forms of forced work, forced sex work, forced labor work, debt bondage in migration communities. So I think it's broader than simply forced slavery. So that's a little bit of a misnomer, but it does have a lot of similarities.
Yeah. So, what are organizations, including your own, doing to help these survivors?
Um, well, thankfully, there's a lot of different ways to address trafficking. So we talked a little bit about the Palermo Protocol, so the sort of prosecution model. So we have law enforcement agencies at the local level, like Human Trafficking and Sex Crimes Task Force here in Houston, as well as law enforcement agencies at the federal level with the FBI, whose goal is to identify traffickers and arrest them and bring restitution and justice to victims. But once persons are identified, they often have a lot of medical, mental health, and social need. They often need psychiatric care, psychological care. Many of them need drug and alcohol rehab services. It's important that a lot of those services are trauma informed, which many are now, moving towards that as a standard of care. There are trauma informed OB-GYNs and trauma informed primary care clinics that victims of violence can work with. There are people whose only goal is education. So we are very focused on educating healthcare providers and healthcare workers in the anti-trafficking space. But think about all the other places we could educate people, in schools and religious communities. And so there are people who are nonprofits whose role is to just go into schools and communities and educate adults and children about trafficking. There are refugee relief agencies that work towards identifying trafficked persons in migration communities. There are anti-trafficking shelters for children and adults. There are trauma-informed social service and case management agencies. So thankfully, we have a lot of partners in the space. In a perfect world, we would keep human trafficking and our differential diagnosis of child abuse and adult abuse, and this would become integrated into the standard of care in all health systems. And then we can collaborate with law enforcement, social service needs, rehab facilities, where they treat other forms of victims of violence.
I'm glad that it's getting the attention it deserves. As a clinician, I know that for our license renewal, we now have to do a human trafficking module. And I think this is very, very helpful. Can you tell us about that a little bit?
Sure. So Texas House Bill 2059 was passed in 2019 in the fall right before 2020. And it was not passed by our team. We did not write the bill. But it was actually passed by advocacy and policy groups that were looking to protect vulnerable populations, including children. And so there was a lot of data that indicated that trafficked persons see healthcare providers during the time they're being trafficked. And in Letter and Wurzel's work from 2014, those estimates are somewhere between 65 and 80% of trafficked persons. And so educating healthcare workers on human trafficking seemed like a good place to start. Just our team has trained probably over at least 10,000 healthcare workers, just the three of us. So you can imagine that that training makes a huge difference when it's scaled. There has been some work published about that. It's called the Texas model, because the question is does education help? And that's sort of what we're interested in is, if we educate healthcare workers, does it increase identification of trafficked persons in these systems? And does that translate into improved outcome and reduce harm caused by the exploitation? And so that work is yet to come. So that's sort of the next step.
Dr. Gloria, what do you think? Do you think it does make a difference?
Well, when I talk, what's interesting is the answer is yes, I do. I do think it makes a difference, because when I was in training, human trafficking was never discussed in a healthcare setting, and now I have students who have taken classes on the topic, and they come to medical school more informed And so I think the conversation around human trafficking as being a global phenomenon and not something that happens just in other countries, that it happens both in our cities and in highly vulnerable communities where there's conflict and natural disasters, really does make it a both local and global human rights issue. And so it's now on the differential diagnosis. When we think about child abuse, is it escalate and elevate to the level of trafficking? When we think about domestic violence, is there trafficking involved? When we think about intimate partner violence, is that something that's happening to an adult male? And so I think it's changed our views about who can be trafficked, and what happens to them when they are. So I think we're starting to move the needle. And so I think eventually it will be part of medical education curriculum, I would hope. And then it becomes standard of care for everyone to take care of victims of trafficking, wherever they are.
You. I really think we all need a note of hope on this. This is such a serious and a weighty topic. Maybe a success story, if you have one.
I say, we have a lot. I mean, I think that's the good thing about working in this space is that that there's really an opportunity to make a difference in people's lives. Some things that sort of stand out are identifying a victim who was a young male, a young adult male, and our learners realizing that men could be victims of sex trafficking and being able to get resources for a young man. I think about a case of a woman who was trafficked as a child by family members and came to us in her middle age. She was probably, in her mid 40s or 50s. And she told us that nobody had ever cared to ask what had happened to her, that she had all these physical and mental health sequelae of her child abuse. And she felt relieved for the first time to be able to tell someone. So she'd been holding that in for decades and had never disclosed it to her family. And she said even her husband didn't know about the trafficking. And so to be able to give patients a sense of relief. And then, that when we think about education of healthcare providers, the question then becomes, and then what? And so that's one of the reasons our program was built, was because it's important to educate healthcare professionals. It's important to screen, but then what are you going to do when you identify them? And so to be able to have specialized resources, postdoctoral psychology fellows and social workers and psychiatrists and a collaborative team to be able to address their needs and to understand what they went through, I think is very empowering as a clinician. And it gives the patient a really, really honestly a sense of hope. And so I think that's why we continue to do what we do, despite these stories sometimes being distressing and sometimes making you question humanity. That sense of hope and change is what keeps us engaged in the work. So there are curriculums that have been developed for children at different ages, from young children to preteens to teenagers, about what safe relationships look like,
Yes.
What force sounds like, what coercion is like. And I think that's where we really need to start, which is understanding. Remember, when we talk about the act and the means and the purpose, the act is not recruiting or transporting or harboring. It's the act between a person and someone they're going to harm and exploit. So what you're looking for is that relationship that you have with a peer or a young adult or an adult a safe one? Remember, there are incredible methods that traffickers can use to recruit children and young adults, or say children, adolescents, and young adults. One of them is by using peers. So, maybe a grown man could spook a teenage girl, but maybe they'd be less afraid of another teenage girl. And so there's a word for it. They're called bottom girls. There's actually a term for it, where the trafficker will identify a recruiter in their ring and say, I need a certain number of girls, go out and find them. And so it's actually not uncommon for girls to be recruited by female peers. And so it's important to have conversations with your children about safe relationships when it comes to both friendships and and adults, it's often not a stranger. Traffickers know that there has to be this level of trust that's developed between a vulnerable person.
Yeah.
And so they develop that trust, and then they intentionally spend time developing a feeling of safety, and then quickly turn to exploit that person, um, and then act on that trust. And so it very rarely is a stranger. So I think having conversations with your children about safe friendships, safe romantic partnerships, and then relationships with safe adults, as well as social media safety, the importance of sort of obvious things. Who are you talking to online? Why are you talking to those persons online? Is it someone you know? And are they safe? And go ahead.
No, I was just thinking that, like, we're talking about, I have two teenage daughters, and how do we keep them safe? And they wanted Snap, and we're like, no, you can't have it. And then, the moment that my daughter got it, all of a sudden, a friend of a friend sending a pic, right? And it was a little bit shocking. And then you even learn, like, even on like social media, you no longer accept friends of friends, right? You have to know them. These little rules for, and maybe that's not even setting the table entirely, but I do appreciate the fact that, when I think about the safety of my daughters, are they equipped? Are they equipped?
And I think that's why these, we're busy taking care of patients. And so these educational curriculum that focus on safe relationships at all ages need to start early, not only in the home, but even in schools and in communities. I always say that, people slide into my DMs. I mean, I'm a middle-aged woman, and I get messages from people that are clearly trying to do me. I mean, I know who they are, but, if I didn't have the kind of social support or education that I do about these issues, like, maybe I would be vulnerable to answering a message from a stranger online.
Very good.
And there are some clinical stories that are usually very suspicious. So when you talk to a young adult, for example, in the emergency room, and they say, I stay with a friend. Like, why? Why are you staying with a friend? Where are your parents? Where's the extended family? Assuming the parents are not okay. So there are some red flags when you're taking a history that will clearly tell you this person is vulnerable. And so while the reality of human trafficking is ugly, who's to say that in the beginning, this victim is not getting some benefit or at least some sense of stability, right?
Oh,
Right.
jeez, yes.
And back to Dr. Mogadam's point, I was thinking about this later when she asked about the intersectionality of substance use. If your social needs aren't being met, like food and housing, and you have a substance use disorder, my first question is, how are you paying for that use? I mean, substances are not free. And so are you being forced to engage in labor, forced to engage in criminality, forced to engage in sex? Are you debt bonded to someone because of a debt, because of a substance use? So clinical questions do help drive a better understanding of whether somebody is vulnerable to being exploited or currently being taken advantage of.
Yeah.
Right. And then the glamorized picture in the media of sex trafficking only, I think, does injustice to human trafficking because human trafficking is a lot of labor trafficking. So the stuff you see in the media might not be portraying a full picture and it might help with recognition, but I don't think it helps necessarily with accurate recognition.
Yeah, I think, obviously from this conversation, Dr. Gordon, one of the questions I have too is, there's a lot of hot spots right now. We think of what's happening in Ukraine and Russia and Palestine, and one or two hot spots even in our own hemisphere currently. But what about the child soldier? What can you speak to that?
Yeah. So when people talk about child soldier, which is a very accurate term because you have a child who's been given a weapon, what you're really thinking about is forced labor trafficking of children to engage in armed conflict. And so the question is that child being soldiered by choice or by force? And when you are in a natural disaster or a conflict zone, keep in mind, a lot of things shift. You have porous borders, weak enforcement of laws, and organized social structures. You get infiltration of smugglers. So again, people who smuggle arms and weapons and drugs and people. And you get often an immediate loss of individual and community safety. And so armed groups often have a driving force. They become agents of security for vulnerable populations, especially for children. And so it may be that they are having their basic needs met by engaging in this armed conflict. Maybe they're getting food or protection or security and housing for themselves or for their younger siblings. So there's often a social push to make joining an armed conflict group, yes, exploitive, but also beneficial for the child. Sometimes there's propaganda around it. Sometimes there's social acceptance of it. Sometimes recruitment is for supportive roles and not even child soldiering. So boys and girls may enter thinking they're going to be armed soldiers or child soldiers, and in fact, they are forced into sex roles for other armed agents. And so there is a lot of overlap between child soldiering and labor trafficking and sex trafficking. But when we think about child soldiering, it is essentially the most extreme form of forced labor that you can offer because it's so dangerous and so deadly.
Amazing. Thank you so much. Before we head out and we kind of go our separate ways, um, we're going to provide a number down below that you can reach out, or a URL that we can provide. What are some of the just like the easy things that people that travel, people that are sort of in business, that we can do to look out for the most vulnerable, or something that like red flags that maybe we can give some notice and maybe see if there's something we can do?
Yeah, so that's a great question. The first thing we tell community members is you're not the police. So please don't try to intervene on behalf of someone. There are law enforcement agents and agencies whose job is to protect people from trafficking. So if you're in the United States and you suspect somebody is being exploited for labor and sex, there's a hotline number you can call specifically for human trafficking. That was started actually by Catherine Chan, who now is the head director of the Office of Trafficking in Persons for the Department of Health and Human Services of the federal government. So it was a project that she started decades ago. And that number is easy to remember. It's 888-3737-888. So you can tell it to someone who you think is vulnerable, or you can call on someone else's behalf. And then that triggers sort of this downstream effect of is that person safe? What kind of resources do they need, et cetera. If you have already identified somebody as being trafficked, and let's say you are working in a foreign country and you're a U.S. citizen doing work abroad, there are what we call NRMs. Those are national referral mechanisms that each country has. The U.S. does not have one. We have our National Human Trafficking Hotline. But if you're in Poland or France or in Africa, there's what we call NRMs, National Referral Mechanisms, and you can look them up. And there's a local number that you can call, and that will get social services, medical services, and legal services to somebody who's a victim in that country. And it's a referral mechanism that crosses all three areas.
Wonderful. Thank you so much. Dr. Gordon, it is a pleasure having you on our podcast. Nadal, as always, it's so good to serve with you. Thank you for all your efforts and all your good work. And I want to just remind everybody that we'll provide the numbers and some links down below so you can help out us as we make the world a better place. Thank you very much.
Thank you for having me.
Thank you.